Good afternoon, everyone, and welcome to the penultimate day of the first PICU World Awareness Week organized by the World Federation of Pediatric Intensive and Critical Care Societies, the WIFPICS. Today is the joint European Middle Eastern collaborative session on extending the boundaries of multidisciplinary research through collaboration. I'm Akash Deep. I'm a pediatric intensivist from King's College Hospital in London and one of the 9 committee members to organize this particular session. Through this session, we'll be looking to discuss about research being streamlined and how we can collaborate across disciplines and across continents, discuss the various challenges and the ways to overcome these challenges. We are very fortunate to have a star-studded multidisciplinary faculty. We've got 5 speakers and they'll be giving 4 talks of 15 minutes each, followed by a panel discussion of 30 minutes, which will be moderated by 3 of my colleagues. We've got Dr. Walid Al-Hazani from Canada. We've got Professor Rob Tasker from Harvard, Professor Mark Peters from Great Ormond Street in London, Dr. Joseph Manning from Nottingham, and Pauline Remakers-Jansen, who is a nursing colleague from the Netherlands. Without further ado, I'm going to invite our first speaker, Dr. Walid Al-Hazani, who is an intensivist and a methodologist and an associate professor of medicine at the McMaster's University in Canada. He is the method chair on several international prominent practice guidelines, including the Surviving Sepsis guidelines and including the Surviving Sepsis COVID-19 guidelines as well. And he has led many clinical practice guidelines with professional societies like the SCCM and the ESICM. He chairs the Guidelines in Intensive Care Development Evaluation Group called the GUIDE Group, an academic group which provides the methodological support for guideline development in the field of critical care medicine. Over to you, Walid. Thank you.
Thank you, Akash, for the kind introduction. It's a great pleasure to be here today and talk to you about opportunities of collaboration with the Middle East researchers. These are my disclosures. I am the chair of the GUIDE group and also CIHR funded for the COVI-PRONE trial that I'm going to discuss briefly during this talk. Before we start, I would like to quote Henry Ford, who said, "Coming together is a beginning, keeping together is progress, working together is success." So I hope that by the end of this lecture, that different groups will come together and keep working until success is achieved. My talk is going to focus on overview of research output from the Middle East. Also, reasons why Western researchers should collaborate with centers in the Middle East. Briefly touch on barriers for research within the Middle East, and also the role of professional societies in facilitating collaborations. Also touch briefly on some successful examples. So as you see, I have a busy agenda to go through. I only have 15 minutes, so I'll try to finish on time, but I suspect I'll go a little bit beyond, so I'm apologizing in advance. For those, I'm sure most of us are familiar with the Middle East, but it's composed of 16 countries. It's a very densely populated area. The population is estimated to be more than 450 million people, and it's slightly more than 5% of the world's population. Also, from an economic perspective, there's a huge variation in the GDP between countries in the Middle East, in which, for instance, countries like Saudi Arabia and Turkey are on the G20 group, and they have high GDPs, and there are other countries with extremely low GDP. So, plus the Middle East also falls in an interesting geographic location that connects 3 continents together. So many reasons why the Middle East could be potential for collaboration and a rich area for research, as we're going to discuss in the next few slides. Also, the background on the Middle East, the medical schools, and again, this slide is based on publicly available information. Not sure how accurate it is. It may be a little bit off, but roughly speaking, there is more than 130 medical schools within the countries of the Middle East. So there is a large focus on medical education and medical schools. And obviously with medical schools, there are faculty members and research enthusiasts in those medical schools. So there's a lot of opportunity to identify interested people. So why bother collaborating with centers in the Middle East? Well, I'm going to discuss in the next few slides the research output and how the population could be unique population as well, and the future trajectory of research in the area and the available resources. Altogether shows huge potential and also may help make some trials efficient, as we're going to see in a few examples. But also, from another perspective, is equity, as these populations are understudied. They're not included in large clinical trials, usually. But also it allows for diversity, including other populations in large clinical trials, which enhances the generalizability of the results. Our colleagues have published this interesting quantitative analysis from mostly 10 leading countries in biomedical research in the Middle East region. These articles were selected from Web of Science throughout years 1991 up to 2018. They focused on non-communicable diseases research. And as you can see in this table that summarizes what they found close to 500,000 publications over the span of the years that were published in more than 12,000 journals. The focus was mostly cancer. Cancer research was rated the top, although the leading cause of death in this area and morbidity and mortality is cardiovascular diseases. Although authors did not look into the reasons why cancer was most studied, it's probably areas that are well supported by pharmaceuticals and also with basic science researchers. So I suspect these are one of the reasons of cancer being the leading research, at least from this slightly older data. If you look at the breakdown of research productivity, so in the Y column is the average publication per 3 years, and in the X column is the years ordered chronologically. And as you can see, the countries are plotted here on the right-hand side. So Turkey seems to be the leading or the highest in terms of research productivity or papers, let's say, number of papers, followed by Iran and then Saudi Arabia. When it comes to cardiovascular research, the distinction between those top countries becomes less pronounced. And you can see that the countries like Saudi Arabia are publishing, or the number of publications have increased significantly over the years, and it's almost close to the other countries, which means that there's more focus on endemic diseases such as cardiovascular diseases. Diabetes also is one of the common conditions in this region of the world. And again, similar observation, you still see the countries like Saudi Arabia, Turkey, and Iran are the leading in terms of number of publications, although the number of researchers on diabetes is less in total compared to other topics. We also interestingly looked at any correlation in those 10 countries between research output and wealth. And they found poor correlation between wealth and research output. So as you can see, in the y-axis is the number of publications. The x-axis is also an old estimate of GDP from 2014. These numbers are outdated now, but at least gives you some perspective. And as you can see, countries highlighted in green here did pretty well. They had high GDPs, and they also did pretty well in terms of publications. So just a reflection of some investment or financial investment in research in those countries, as opposed to other wealthy countries like UAE and Qatar as well, that the number of publications did not correlate with income or wealth of that country. Also, researchers in this on this paper looked at the correlation between research output and population. And again, they found a good correlation. So the R square is about 0.8, which is excellent correlation between the population density. So the higher the population, the more the research output, which makes sense, as opposed to countries with low population, the research output was less. In addition, they also looked at the proportion of papers in which international authors were listed as a surrogate for international collaboration. And they plotted this on this bar chart. Red is for cardiovascular disease, green is for diabetes research, and blue is for oncology. And the countries are plotted here on the x-axis. Interestingly enough, collaboration is already happening. As you can see, countries like UAE and Qatar, Saudi Arabia, some countries like UAE and Qatar did not have high productivity, but they did have high collaboration rate, as opposed to Middle East countries like Iran and Turkey, where they had a higher research output in terms of papers, where they were the lowest in terms of collaboration with international researchers. The countries that were ranked in order in terms of collaboration proportion were the US, UK, Germany, and France. So collaboration is already happening. And these numbers, as I said, are based on slightly older data that probably have changed, but also that just gives a trajectory and an idea that collaboration is already in place and it's happening. Authors also took it one step further, and they looked at the correlation between international collaboration and the citation impact. And they found a decent correlation between that, meaning that as the proportion of collaboration goes up, the higher the collaboration with Western researchers, the impact factor of research that is published goes up, which means that the research is probably more visible and probably have higher chances of being published in higher impact factor journals. Other colleagues from American University of Beirut looked at medical research in output in Arab countries. And as I said at the beginning, most of the Middle East is formed by Arab countries, so they could be used as a surrogate to research productivity. So they looked at publications between 2007 and 2016 and compared the publications from the Arab countries compared to the rest of the world. And as you can see, although research overall was going up in terms of number of publications, there was at least threefold increase in the number of publications in the Arab world, meaning that the research trajectory is going up significantly. They also looked at the leading countries in terms of number of publications per year. Egypt came in the first place, second is Saudi Arabia, and other countries as well followed, which just gives an idea about the engagement in research projects and academic productivity. We also looked at several institutions based on citations, ranking by citation. So the average citations per paper was used as the variable to rank those institutions. American University of Beirut came first, and several institutions from Saudi Arabia, like King Abdulaziz University and King Faisal Specialist Hospital, came in second and third, and not by far, they all were pretty close to each other in terms of average citations. Also, they looked at the impact ranking of the proportion of papers published in the top 10% of journals. Again, King Faisal Specialist Hospital ranked first from Saudi Arabia, followed by American University of Beirut, but I think they all did pretty well, at least from the top 10 selected in this paper. So there's more focus also on quality. So we see here that the research trajectory overall is moving forward with a steep curve in terms of research output and quality as well. There's also a unique variable about the population in the Middle East. Several comorbidities that are affecting the world also affecting this area, including cardiovascular diseases, high prevalences of hypertension, diabetes, metabolic syndrome. Believe it or not, in the WHO, they also quote more than 70% prevalence of obesity, especially in the Gulf area, where sedentary lifestyle and higher income probably resulted in higher rates of obesity. So it's a rich environment for research for preventive medicine. In addition, culturally in this area, consanguinity or relative marriages is probably the highest in the world. And this leads to unique cases of hereditary and genetic diseases are available that could be also studied in a broader way, and including larger sample sizes. I'll give you an example that I was involved in a clinical trial looking at sickle cell disease. So patients with acute vaso-occlusive crisis presented to the emergency department. This group was able to randomize 278 patients, which is probably the larger than, or one of the largest trials in the field. But the striking thing that this trial was conducted in a single center in Saudi Arabia in only over 12 months. So it took them 12 months just in a single center to randomize those patients. So it's very high prevalence of a disease that is rare else in the world, and there's a huge interest in understanding this disease and conducting clinical trials. Another population aspect is the unique distribution of infections. So bacterial infections, viral infections, and parasitic infections. There's diversity in terms of the prevalence of those diseases and their abundance. And this is related to the dense population and the diversity of people living in this area. An example of a unique example that occurs probably only in Saudi Arabia is the Hajj season. So Hajj season, there's more than 2 million people who gather in a very small area for 7 days. And this gathering is not only a rich environment for disease transmission, but also a rich environment for studying infection control, infection prevention, infectious disease, acute medicine, crowd management, name it. It's a very rich environment. And also the recent 2030 vision in Saudi Arabia have explicitly said that the target expansions will accommodate for up to 5 million people per season. So huge number of gathering that probably doesn't occur anywhere else in the world. Colleagues have published an interesting paper in The Lancet looking at leading causes of death in the Middle Eastern countries and the trajectory over time. This just shows the focus on diseases that are endemic in this area. So as I mentioned before, obesity, diabetes, high blood pressure, they seem to be on the top of the list, including also other conditions like smoking, occupational risk, etc. So, these changes in demographics are also interesting and also worth investing in terms of research. I'll touch briefly on funding and resources. There is no explicit data on how much is invested in health research in the area. But as a surrogate, we could look at the GDP. This is publicly available information, and it's color coded based on the distribution of annual GDP. As you can see, countries like Saudi Arabia, for instance, which is the largest country in the Middle East, and also is associated with the highest GDP as well in the country. But there's also variation, as you can see, which also gives a unique perspective, although having similar population, but the socioeconomic status varies considerably in this area. Also, another surrogate for investing in health research and in health care in general is the trajectory of improvement of in number of deaths, or the proportion of deaths per 100,000 population over time. And as you can see here in this Lancet paper, that over the time, the overall mortality in the North African and Middle East countries have come down significantly over time, and this probably reflects better attention to healthcare and also investment in that field. So for the future trajectory, other than the things that I mentioned, the increasing research output in terms of quality and quantity, there is also focus on academic advancement in those areas. For example, in Saudi Arabia, the 2030 vision now includes a mandate to get at least one of the academic universities to be in the list of top 10 universities in the world. So this equals to more investment in academia, more investment in research and building infrastructure, again, highlighting the rich environment and potential for this area. Obviously, with all the pros, there are some challenges that I will touch on briefly. Colleagues also did a survey of 329 healthcare workers, mostly are physicians, and they identified several barriers. And the most common reported by physicians was lack of training, but also lack of policies and procedures, financial support and infrastructure, but to a lesser extent is lack of time and incentives. If you break this down by areas, and again, it's color-coded for the Gulf area, the North African countries, and the Levant countries. It seems that countries with poor income, they have challenges almost in every aspect, while other wealthy countries, they have challenges mostly with expertise and infrastructure. So this also, again, highlights the potential challenges in the region. There are also additional potential barriers that could contribute to this, which is legislations that are not probably available, or if available could be slightly different or significantly different than those available in the Western countries. Also, quality monitoring of research is probably required, and there has to be systems to ensure a quality of research. And again, any investment would require time. I suspect collaboration, especially in the underdeveloped countries, would require building capacity and time. So it's kind of an investment for the future. So how can the societies or professional societies help? Well, this is my own perspective. I think societies have a mandate in terms of education and mentorship, and I mean education with regards not only to medical education, but also research education and connecting interested researchers to those who could mentor them or collaborate with them in the Western world. Also, it allows networking between even well-established researchers in the Middle East and those otherwhere in the world. Again, one of the areas that I'm working on extensively is clinical practice guidelines, and I see this as a huge opportunity for collaboration. Usually those guidelines are led by professional societies. So societies could contribute to these international collaborative efforts, and also could help in identifying areas of prioritization for future research. Also, probably involving colleagues from underdeveloped countries or from the Middle East, specifically since this is the topic of the day, in conferences, in research or academic groups or different activities, also could enhance opportunities for future collaboration. Also, there may be opportunities for providing incentives, awards, or recognition to successful collaborations. All these together, I believe, could help in pushing the collaboration circle forward. The last thing I'm going to talk about, and again, I apologize for staying too long, is the successful examples that I've seen. One of the most successful examples are the Canadian critical care trials group. That was probably the first critical care trials group that have been formed in the world. And as you can see in this network, plots different critical care trials group from the world. It also highlights the collaboration, and the collaboration between Canada and Saudi Arabia, for example, and the agen and the ANZICS group have resulted in significant research output that actually changed practice all over the world. So several RCTs, high quality RCTs that change practice, including my practice, have been published as a result of this collaboration. Another successful example is the surviving sepsis, recently published surviving sepsis COVID-19 guideline that involved collaboration between researchers across 14 or 15 countries around the world, including those from the Middle East. And it probably was one of the most highly cited COVID-19 guidelines last year. A last example that I'm going to use is our own COVI-PRONE trial, which is a clinical trial on awake proning in COVID-19 adults. And we were lucky and honored to have two countries from the Middle East, Saudi Arabia and Kuwait, to participate. We have overall 22 centers. But what was really striking is the number of recruitment. Kuwait and Saudi Arabia have contributed to almost 50% of the patients in this trial. And not only that, but their adherence to protocol and data quality was outstanding. So this definitely helped us to complete this trial within a year, which was the proposed time, and was an excellent example for collaboration. This is my last slide, and I would like to thank you for listening, and I'll be happy to take any questions during the plenary session. Thank you.
Hello everyone, I hope you're enjoying the Europe and Middle East Day of World PICU Awareness Week 2021. My name is Simon Gates, I'm a physiotherapist in PICU in Nottingham, United Kingdom, and I'm here to introduce the next session that we're going to have on our programme today. So I'm very, very pleased to have two excellent speakers, Pauline Remekes-Jansen and Joseph Manning, to talk about nursing lead in collaborative research. Joseph is a colleague of mine in Nottingham. He is a clinical associate professor in children, young people and families nursing, as well as a charge nurse on the pediatric critical care outreach team. Pauline is a doctoral candidate at the University of Amsterdam and also president-elect of the European Society of Pediatric and Neonatal Intensive Care. So without any further ado, I'm going to pass you over to Joseph and Pauline, and do continue to enjoy the rest of our day.
Okay. Welcome to this virtual congress, whereby Joseph and I will talk about nursing-led collaborative research, and we will thank the organization for the opportunity to speak at the PICU Awareness Week and all the fabulous work they have done to make this week possible. Owen and Joseph have something to disclose. In this presentation, we will talk about the role of the nurse in 2021, the priorities for PICU research, the collaborative approach to research, current status quo, and the impact and ambition for the future. The year 2020 has been recognized as Year of the Nurse and Midwife, but due to the pandemic and the pivotal role nurses have and continue to play in the response, 2021 has also been recognized as the Year of the Nurse and Midwife by the WHO. This is an opportunity for registered professional nurses to come together at global, national, and local levels to influence and inform the role of the professional and education required for a workforce that is fit for the health needs of children and young people of the future. The state of the world's nursing 2020 is investing in education, jobs, and leadership. And this comes as the world witnesses unprecedented political commitments to the university health coverage. At the same time, our emergency preparedness and response capacity is being tested by the current COVID-19 outbreak and mass population displacement caused by conflict. Nurses provide vital care in each of these circumstances. And now more than ever, the world needs them working to the full extent of their education and training. If we look at the role of the nurse as the largest professional group of the global healthcare workforce, registered nurses are pivotal to achieving the WHO triple billion target. They make a central contribution to national and global targets related to a range of health priorities. And this includes university health coverage, mental health and non-communicable diseases, emergency preparedness and response, patient safety, and the delivery of integrated people-centered care. It is important that nurses know the different layers of impact from the individual to the population levels. And therefore, education for early career regressive nurses should in any case focus on clinical excellence, critical inquiry, innovation, and transformational leadership. The care of children in the PICU is very complex. It is a very heterogeneous group with a wide range in age and comorbidities. Due to the complex care, there are many research topics, almost all in the basics processes in critical care for children. If we look at the research agenda in pediatrics from intensive care medicine, we see that there are many clinical important research topics described, such as ventilation, sedation, and fluids and feeding. Since the PICU nurse is the monitor of the doctor and the patient's lawyer, the nursing research topics will be in the same areas.
Thank you, Pauline. This has been confirmed again in a recent UK research prioritisation exercise that's been led by Professor Livon Toom and colleagues on behalf of the Pediatric Intensive Care Society. This Delphi study of professionals and families identified the top 20 priorities for research. And whilst there may not be complete agreement across the different stakeholders, there is certain commonality across these professional and parents' views. And you can see that from this table here. It's evident that these priorities transcend professional practice domains. They differ in focus relating to population, differ in relation to phenomena and to interventions, and therefore generating the science and also implementing the new evidence to advance clinical care within the PICU and beyond warrants a collaborative approach. Now, collaborative research can take many forms as outlined by this figure, and it goes from the multidisciplinary, where the focus is a thematic umbrella, to a convergence approach to research that allows us to not just generate knowledge for scientific advancement, but also for social change and the creation of new paradigms of thinking and action. But to do any form of collaborative research, we really need to break down those conventional barriers or boundaries that constrain us. And these include the professional, the methodological, and the geographical domains. And really to achieve this, we need to broker linkages across disciplines and sectors with a mindset of team science. And that, by liberating a team science approach, it will enable us to acknowledge and to really maximize on the diversity of insights that we have in relation to the clinical, the methodological, and the experiential expertise that we have through collaboration. Collaborative research brings many benefits, and we can really maximize the impact and reach of research through collaboration. It enables us to know who will be using the products of our research, enable us to broker novel relationships and ways of working that exist beyond the research, and also enables us to broaden the methods and ways that we communicate and influence through our research. So what is the status quo? Well, as a paediatric critical care community, we already have nurses leading hugely successful programs of impactful collaborative research. And we cite a few on this slide. These are programs that are diverse in their focus and the methodologies that are employed, but are absolutely aligned to the priorities for our clinical care. And so we're very much standing on the shoulders of giants, but certainly as a global community, we really need to support and lift other nurses to lead, to ensure that the future of nurse-led collaborative research in the paediatric critical care field is secure. So to conclude our presentation, really the role of the PICU nurse in 2021 and beyond includes leading and developing collaborative science. We know that the priorities for PICU research are all of our priorities. They've been identified, and we have some level of consensus across health professionals, across teams, and across our key stakeholders, including our patients and families. We absolutely have to go on this journey together to foster and generate new science, and a team science approach is absolutely fundamental to that, so that we can harness the diversity of clinical insights, the experiential insights, and also the methodological expertise that we have to hand. We have a growing global community of nurse scientists, and we have evidence of hugely successful and impactful programs of research, but we need to sustain and grow that, and that is really dependent upon a strategic commitment and investment in the development and support of nurses to lead and develop science, because unless we do that, then we're not going to truly realise the impact that will have for our patients and families and our workforce in relation to advancing clinical care within the paediatric critical care domain. Thank you very much for your time, and we look forward to the questions.
Hello everyone, I'm Anna Zanini, a pediatric intensivist from Padova, Italy, and I really hope that you are enjoying this Europe and Middle East region day of the WIFPICS World PICU Awareness Week. I'm introducing Professor Mark Peters now, who is helping us to explore the difficult world of funding and legislation in collaborative international research. I'm sure that all of you already heard about Mark. He currently works at the University College of London Great Ormond Street Institute of Child Health, and he does research in clinical trials, pediatric intensive care, and emergency medicine. His current project includes FISH, fluids in shock, fever, Oxy-PICU, first ABC, and SCARF. I'm sure that you already know him very well, reading his article and publications, and now I'm leaving the floor to him. Thanks a lot for joining us today.
Hi, my name is Mark Peters. I'm grateful for the opportunity to speak to you. I've got this rather challenging title of how to navigate funding and legislation. It's kind of challenging because the answer is obviously different for every healthcare service you're going to work in. But I'm hoping to give you some thoughts from a few years in the business. And I'm going to start with the downside. One of my main thoughts about this is that money drives a lot of success in research. And so once you have money and demonstrate you can use it sensibly, it's easier to get money. Again, the funders naturally worry about risk attached to spending their usually public money. So you could say it's all about the money. Perhaps that sounds a bit negative. Well, I think the truth is that whatever the money situation, our investigators around the world, our community, does manage to do this. If I point you to the wonderful website, PICUtrials.net, this is Mark Duffett from Canada's curated site that collects all of the randomized controlled trials in our field that are published every year. And when I last accessed it, it would just hit the lovely round number of 500, dating back to 1986. There's a few things to note in these data. One is that funding is not always reported. Only just over half the studies have funding reported, but commercial funding is infrequent, so it's most often government or charity money. Should also point out just over here that actually over 65,000 children have been randomised into clinical trials in paediatric intensive care. That's obviously a tiny fraction of the total number who have been critically ill and through our units in that time, but it's not an insignificant number. So where do those trials take place? Well, genuinely globally. The US, South America, Europe, India, Egypt, and within Europe, a fair distribution. So we're all at it. We all have some degree of success, therefore, in navigating our funding and regulation. But what specific advice could I give you? Just saying, actually, one more point, that 41%, so the inverse of this, are from low and middle income countries, which is important because obviously that's where a lot of the critical illness resides. So if I were going to give you some advice, I would suggest you get to know your funders or funder as well as possible. And the UK, we're lucky enough to have a national system called the National Institutes for Health Research. It comes in a couple of different flavours depending on what type of research you're doing, and the one that is perhaps most relevant for us is something called the HTA, the Health Technology Assessment Agency. We had some success, not least by engaging in the HTA's infrastructure. In particular, they give the option for suggesting subjects that they then take forward as commissioned calls for research. We also managed to get a couple of our doctors and nurses onto the grant awarding boards. And it's just very interesting to see how research in children can sometimes be considered by people who are not working with children. I certainly overheard the comment, I don't think you should do this kind of work in children. I think that children should be protected from research, whereas I think most of us who do research in children think children should have the opportunity of accessing research, because non-specifically, research tends to improve outcomes even if the trial itself is not effective for the treatment under review. So you have to get in there, you have to engage with these kind of institutions and try and change attitudes. Some specific aspects of what the HTA require, there are two linked factors, and I think these are critical. That families and patients have to be involved in designing the study. It has to be something that is of importance to them. And so that's relevant both in the language you use, in the selection of the problem, but most of all in what you measure as an outcome. The HTA, and I think us as clinicians, should not really be interested in biomarkers as outcome. We should be interested in things that matter to patients. Are they surviving? What condition are they surviving? How long does it take them to get better? That sort of outcome measure that is meaningful to the majority of parents. So real world research with clinically relevant outcomes, and an application to the HTA that didn't include that would undoubtedly not be successful. This system with the National Institutes for Health Research has been in place for about 15 years now, and UK PICS had some early successes with our control of hyperglycemia study and our clonidine sedation study, and our catheter-associated infection study. This was a randomization between heparin-bonded and normal and antibiotic-bonded central venous catheters. And then we had a little bit of a hiatus after that, this initial flush of funding, if you like. We then found it a bit more difficult to get income. This is the CATCH study. It was published in 2016. Keelan Malcolm, many of you will know, was a major contributor to that. And although it showed some differences in the central venous catheters with respect to infection, perhaps its biggest impact was on the process of delivering trials. And it, in particular, it used what became known as a deferred consent or research without prior consent approach. So the line is placed and then the families are approached afterwards for permission to use the data associated with that line. And this became a feature of our subsequent work. Although we had to do assessments in each individual study of the appropriateness of this technique, we were able to use it and summarize that in the publication you see here, but it was relevant to a number of the studies you may have heard of that are visible on the screen there. And it gives us access to a population that previously would be a challenge to address in trials in critical illness. So research without prior consent. And importantly, this is popular with our patients and families. 19 out of 20 on average were supportive of using this kind of method, which is really encouraging and important. So having learned that from CATCH, we were able to move forward. And the next element that I think is key and may be relevant in your setting is to conduct a prioritization exercise. So what are the important research questions you want to undertake with your your clinical colleagues, but also with the families and patients, what's important for them. And we conducted one of those back in 2014 and have recently done another one. As a result, we had some meetings at Lord's Cricket Ground, and a number of studies subsequently took off and were funded. And the last 7 or 8 years has looked really very busy with increasing numbers of studies taking place. This is roughly where we are now. I mentioned a research prioritization exercise. This is the most recent one, published in PCCM just in December 20, and led by Livon Toom, who many of you will know. There's a lot of data in there, but just to give you a flavour, many questions were put forward and then prioritised by the community. And there's a few of the examples here, the top rated subjects for further study: staff distress, always feeling we could do better with sedation and its impact on length of ventilation and delirium. Oxygen saturation targets, pleased to see this in here. This is my study, as you know. Choices of fluids and staff well-being and retention in jobs appeared a number of times, not just in the top 5. There were some other things that maybe are unsurprising to appear as highlights. But I should emphasise that these prioritisations were not just from medical staff. They included approaches to families who engaged with the research process and had some family and child-friendly vignettes, if you like, about potential study projects, and they were asked to score on whether that would be of interest or importance to them. And so we think this is quite a robust prioritization exercise, and it's certainly helpful to be able to say that back to the funding body about this is prioritized by our field and our users. So essentially, our engagement with the HTA and the associated clinical trials units that we've worked with at ICNARC have allowed us to professionalize PICU research. So, and some of the elements about this that I'd like to mention is the research without prior consent work we did. The use of our PICnet registry, which is fabulous for us not having to replicate data. Collection that allows a more efficient design of our studies. I wish I could say more about that, but no time. As I said, engagement with the clinical trials unit, who are already well established in ICU research in adults. Many of you know Kathy Rowe and David Harris and Paul Mountsie, who are leaders at ICNARC. We also demonstrated that we weren't being overly ambitious by attempting pilot studies in small numbers, hundreds, 100 patients or so, to show that studies could or couldn't work. And obviously this is one way of reducing the risk for the grant awarding body. And then there's a point at which, when you're doing studies frequently enough, that it becomes viable to hold research nursing posts open at each site, awaiting the next study. And maybe we've got to that point or close to that point now. And work on outcomes, I wish I had time to discuss, but outcomes that are both that trade off their clinical importance, but also their ability to be powered within the kind of populations that we have accessible to us. Clearly, mortality is unlikely to be suitable given the low rates. But I'd also just like to suggest that part of the PR involved in selling a clinical trial is that you have to design a trial that the result matters regardless of what it is, whether it's for or against an intervention. Good projects have reach. And I think if you design a study that focuses on one of the many bedside processes that are delivered to the majority of our patients, and perhaps that's sedation, perhaps that's fluids, perhaps that's vital sign targets, then whatever you find, it is going to either reinforce or refine our practice. And this is a point we made with colleagues 4 or 5 years ago in intensive care medicine. So studies that affect the treatments we offer to a high number of our patients are perhaps our first priority in clinical trials. I just want to, as an aside, show you something that just appeared in Nature a couple of weeks ago. This is a puzzle that's set to subjects of a trial, and the question we were asked was, what do you have to do to this Lego shape to make this top piece more stable? And what most people choose to do is to add additional pieces of Lego underneath on each of the corners here to make it stable. And of course, that's true, but a simpler solution will be to take something away. Just that one block there on the corner and press the whole thing down. And the point of the whole study that's much more scientific than I've just presented it is that there is a bias in favour of active solutions, of additive treatments. That's particularly true in intensive care. You could argue we're not very good at taking things away. We could argue that all of the benefits in intensive care recently has been with doing less to our patients, less intensive treatment. A minimum safe treatment might be more appropriate. And you can think of lots of examples of this: parenteral nutrition, transfusion, sedation, glycemic control, or even blood pressure targets. So no harm or even benefit of being less intensive. And so perhaps an appealing strategy for a funding body is to pitch a study in those terms, and be aware that every treatment we have has a risk of an adverse effect. And obviously the risk benefit is dependent on the population in which you are studying. High risk, the more likely benefit, and low risk, less likely benefit. So my little summary then is that if you're trying to navigate funding and legislation with respect to getting clinical trial work undertaken, you need to think carefully about what's an answerable question. And that might be something that has a large number of patients exposed to this intervention. And it has to be something that matters to our patients and to our colleagues. You can lower the risk for the funders by either having a track record as a group or by demonstrating pilot work in the field. And just whilst it's always tempting to think of more and more sophisticated and clever solutions, I think we as specialty have not yet come to the end of the value of simple questions that address possible simplifications of our care. And that's certainly the appeal, I think, to funding and legislative bodies. Thank you. Happy to take questions or comments at the contacts here. Thank you very much.
It is my great pleasure to introduce to you our next speaker, Professor Robert Tasker. Professor Robert Tasker is Professor of Neurology Anesthesia at the Harvard Medical School in the United States of America. And he's chair of the Neurocritical Care Program at the Boston Children's Hospital in Boston. He's an expert in the field of pediatric neurocritical care and is a member of the Cerebrovascular Surgery and Intervention Center at Boston Children's. His expertise is in clinical neuroscience, computational physiology, and translational research. And we are very happy that he wants to share his thoughts on databases, epidemiology for research, and what do we really need to know.
Welcome. My name is Robert Tasker, and I am the Editor-in-Chief of Pediatric Critical Care Medicine. I don't have any relevant disclosures to make at this time. Today I'm going to cover three functions of collaborative epidemiological research. Essentially, they are to generate large data sets of PICU patients, to determine standards in PICU practice, and to compare effectiveness of PICU therapies. So in regard to generating large data sets with collaborative research, historically, this has resulted in the development of severity of illness scores and the ability to assess and compare performance between units. And the most famous example of this was the comparison between the Trent region in the UK and the Victoria state in Australia, looking at two different models of pediatric intensive care. And for this, the research teams developed the Pediatrics Index of Mortality. Now the Pediatric Index of Mortality is a well-used instrument across the whole of the UK, and the PICANET team produces an annual report which is open access online. The American equivalent of this was Murray Pollock's work with the Physiologic Stability Index, which developed into the PRISM score, which is now up to its 3rd version and other iterations. So that was the historical perspective of these data sets. That type of work is now completed, and I can't see much in the way of new components to that type of research. So where are we in the present day? At the present day, large data sets are created to monitor specific PICU cohorts, and I'll show an example of that. And the next iteration, which we haven't really seen yet, will be the harnessing of the electronic medical record and machine learning and artificial intelligence to give us greater insight into the populations who we serve. So in terms of specific cohorts within the PICU, these are groups and groupings who have published in PCCM over the last 5 years. And as you can see, there are a number of specialisms, a number of countries, and a number of registries and consortia. So in the UK, there's the Transport Service in London. Around the world, there's the Extracorporeal Life Support Organization. In Asia, there's the PACMAN Consortium. In the cardiac ICU, there's the PC4, and as you can see, PICANET. At the Palisi meeting this year in 2021, there were a number of collaborative groups who were presenting their data, and this is just a list of the groups. So BACON is the group involved in bronchiolitis. PARDI is the group involved in lung injury. PEDAL is the group that's involved in large data analytics. The RESTORE group looking at sedation in the ICU, and the post-intensive care syndrome group. So many groups. What I would draw your attention to, if you're involved in groups like this, is the JAMA Statistical Guide to Methods that was published in 2020. And the last 13 chapters of that book is devoted to the construction of large data sets, how you check on the validity of those data sets, and how you do research with large data. So well worth looking at. Then, of course, when you come to write up your work, there are guidelines to follow, and these can all be found at the Equator Network website, which is open access. So that was the first function of collaborative research. The second function is to determine standards, and this falls into 2 categories. First, either using the Delphi mechanism, or second, using the techniques of guideline development and meta-analyses. The most recent examples of the Delphi mechanism in PCCM is the Bright Star group, who have published on an algorithm for using blood cultures in critically ill children. This is online on PCCM now. It will be in the September issue of PCCM. And then, of course, there's the February 2020 guidelines document and the Surviving Sepsis campaign, which is just one of a series that the journal has published. So this is just to highlight the modified Delphi approach from the Bright Star group and their material that is available now. And this is from the Clarivate or Web of Science website, showing the Surviving Sepsis campaign guidelines, which is a highly cited paper and an extremely high altmetric score. Well, having done all of that work, the next obvious question is it worth doing all that work? And this is a great editorial that was published by Warwick Butt in 2019 and worth a read. The final function of collaborative groups that I'd like to talk about are research networks and the development of comparative effectiveness research projects. And essentially these are assessing and comparing therapies. And many people around the world will have been involved in the ADAPT trial, a comparative effectiveness research project looking at traumatic brain injury management. Briefly, I just want to tell you about the Pediatric Status Epilepticus Research Group, of which I'm a member, the PSearch. Back in the sort of early 2010s, a group of us got together, headed up by Toby Lodenkemper, 11 centers with neurology and PICU in the United States. We decided on what was our particular topic of epidemiological interest, which was refractory status epilepticus. We devised a robust definition of that and just tracked and collected patients after IRB approval at each of the centers. We started with funding from the American Epilepsy Society, and since 2014 to the current day, we've produced 17 papers which have looked at various aspects of treatment, intervention, and care of these patients. So again, you find a particular entity that you're interested in, get together in a group and examine with prior hypotheses what it is that you want to know. So those are my three functions that research groups in WIFPICS may be interested in when considering epidemiological research. Then the next stage is, well, you've got to write it up and present it in the literature. And in the March issue of 2021, I provide an outline for a 2,500 to 3,000 word structure, paragraph by paragraph, as to how you can present your data in an effective way. The next step is getting your document published, and it's not always straightforward. Even if a manuscript meets reviewer agreement on technical execution, the document has to be providing novel information. You need robust and stable data that is free of harms to patients. You need to ask whether or not your manuscript is going to change clinical practice or change thinking, and are the conclusions generalizable to the international places of practice of the readership. So with that, I'll end. Thank you very much for your attention.